Hello, everyone. Thank you for these 12 wonderful months, and let me just run through this presentation very quickly. I'm Caner. I'm working at the Department of Anesthesiology still, and I'm working on 3 articles, which are all concerning different aspects of managing patients with liver dysfunctions. I have 3 projects, and I separated them into 3 settings: a surgical setting, ICU setting, and a preoperative and perioperative when it comes to surgery. We are trying to tackle liver dysfunction from as many angles as possible. My first article is about preoperative administration of glucocorticoids against postoperative complications. A little background. Basically, liver surgery is still very dangerous for patients. Mortality can be up to 20% and complication rate can be up to 48%. And we think that the underlying cause could be operative stress, it could be injury to liver parenchyma, but we are particularly interested in the subsequent dysregulated immune response, which can evolve into a systemic issue. And as a solution, many researchers have been testing immune modulation, and by this we mean steroids. Now, the premise of our study is that in the enhanced recovery after surgery protocols in 2016, preoperative administration of glucocorticoids has been recommended, albeit with moderate level of evidence and a weak recommendation. And this recommendation guideline was based on 2 meta-analyses. Since then, 2 more have been published, and the latest one, 2021, actually for the first time found significant results in reducing postoperative complication rates. However, since then, 3 new randomized controlled trials have been published, which double the patient size. So we wanted to make sure that the level of evidence is actually still strong. So we wanted to see the efficacy of glucocorticoids in reducing complication rates. Did it? Kind of. Well, the odds ratio was 0.71, but we did not reach statistical significance. There is a tendency, that's for sure, but this is absolutely contradicting the latest meta-analysis. And therefore, we concluded that this intervention does not significantly reduce overall complication rate. Also, there are no statistically significant differences between particular complications either, nor in the length of hospital stay. And the level of currently available evidence is insufficient to draw any conclusions regarding the use of glucocorticoids in liver surgery. As you can see, we also performed these meta-analyses on different complications, and we have failed to find any statistically significant result. Only in wound infections, there was a statistical significance, but this should be taken with a grain of salt, because it's very difficult to explain why this is happening, because there are multiple hypotheses about the relationship between wound infection and steroids. So this is part of our discussion. And with perioperative outcomes, length of hospital stay, operative time, and so on, no statistical significant difference. When it comes to laboratory outcomes, we actually could not perform meta-analysis due to poor data availability. However, this is a systematic review, and we gathered all of the currently available evidence with all of its good and bad. And there definitely seems to be a tendency for clinical trialists to discover statistically significant results when it comes to laboratory outcomes. So perhaps in the future this could be an important point around we should design a clinical trial. In summary, just like many of your projects, this one also included only randomized trials. We have the largest patient pool to date. The most broad range of outcomes have been analyzed on this project, and as with everyone else, it's fully compliant with international guidelines. And limitations, we unfortunately could not perform subgroup analyses, and we also could not perform meta-analysis on our secondary outcomes, namely the laboratory outcomes. So therefore, we we recommend that recent recommendations made by reviewers and trialists to use glucocorticoids for this purpose should be reconsidered. And as for research, it is clear that future studies should be designed especially to generate better clinical evidence, as the currently available literature is insufficient to draw any conclusions. Our manuscript is complete. It's sent to language editing and plagiarism check, and we plan to submit it this week to the Annals of Surgery. My second project is about goal-directed fluid therapy and its effect on postoperative liver complications. This project is in revision phase. We are going to check how can we work out this project. But basically, we are interested in patients undergoing major liver surgery and comparing goal-directed fluid therapy with standard fluid management. And primary outcome, we are interested in complication rate. Our third study is the hemadsorption therapy for critically ill patients with liver dysfunction. Now, a little background. Again, critically ill patients may develop a liver injury. We call this an acquired liver injury. And acquired liver injury is an extremely dangerous situation that clinicians can see in ICUs. It rapidly deteriorates into acute hepatic failure if left untreated. But how can we treat it? There is no ultimate treatment, unfortunately. We can manage complications, metabolic abnormalities, encephalopathy, multi-organ dysfunction syndrome, all these horrible things. We can bridge the patient to a liver transplant, or we can keep them on life support. But there is a novel strategy called hemadsorption. This is a blood purification system which can absorb cytokines, it can absorb inflammatory mediators, it can reduce bilirubin and other potentially toxic molecules, and it can also improve liver and kidney functions, leading to a more viable bridge to transplantation. With this study, we aim to summarize and synthesize all currently available evidence on hemadsorption for ICU-acquired liver injury. Again, we are interested in patients with critical illness. We want to analyze mortality, liver functions, and cytokine levels, but also we have secondary outcomes. We conducted our systematic search on 5 databases, and we ended up with 31 articles. And let's not say unfortunately, but it just so happened to be that they are not randomized trials. So maybe you have a better study than I do. And we also have some preliminary results. For example, the post-treatment total bilirubin. There is a statistically significant reduction of bilirubin. So maybe yet there is something interesting in this article. We submitted our abstract to the European Society of Intensive Care Medicine's Congress this October. We got accepted, and we are proud to be presenting the TM there. And as the progress, I am right now in the process of assessing the risk of bias. And I thank you very much for your attention. These were my 3 articles. And see you in 6 months or something. And please, questions.
So thank you for your presentation. Jump to please your slide where you show the amount of given steroid on your first project, because there was a huge difference. I saw methylprednisolone 10 milligram per kilogram and 30 milligram per kilogram. So my question is, what is the RH recommendation first? And second, if we're thinking about, so for example, the last 2 articles give 3 times higher dose, which is, I don't know whether significant or not, but in my daily practice, I think it's a huge difference. So
You're absolutely right.
When we are thinking about some subgroup, according to the RH guideline, what would be the result?
So here's the problem. There are no guidelines about the dosage. This is basically set up by the clinicians. And there is no evidence that suggests any superiority between either dosage strategies or actually the active compound that is being used. Because as you can see, they both used synthetic and natural glucocorticoids. We don't know which one's superior. They use different dosage strategies. We don't know which one's better. And I can assure you that this is emphasized in our article, that future clinical trialists should take heed and they should be considerate of this, let's say, lack of evidence or lack of knowledge in this field, and they should fill in the gaps.
How many statistical analyses were done in this?
In this one?
Yes.
11.
11. I think it's a pretty big number. Therefore, maybe you got a statistical significant result for wound healing. Am I right?
Wound infection.
Yes. So maybe it's some kind of an artificial significance.
I mean, this definitely deserves further investigation. That's no doubt. However, we are not in a position right now when it comes to our knowledge about steroid, let's say steroidology, where we can certainly say that this is why wound infection was statistically affected. Because we have many different ideas, but maybe one idea is better than the other. We just simply don't know yet.